There we go. Okay, sorry for the kerfuffle. I'm here, ready now. All right. So today we're talking about cardiac dysautonomia, or POTS. Is the most common one that we know of, but there's a couple of other ways that we can classify it as well. Don't mind Angus making little yippy noises. He's very excited by this bed. So we're going to go through what those are today. Here we go. So just for those watching at home and for those, I know everyone here knows me, but I'm Steph. I'm an osteopath that works here at North Canberra Osteopathy. I work exclusively now with hypermobile teens and adults, but I still work with all children. I have lived experience as I have ADHD, and I am currently seeking a formal heads and POTS diagnoses, still seeking the POTS diagnoses because that one cardiologist I went and saw was not the person to see for POTS, but we all know about that. I am very passionate about all things hypermobility, both from my own lived experience, and then I started seeing it in a lot of my patients. That's why I now only see those people, because I love researching more and learning more about it and teaching it to you guys, which is why I'm here. I also love reading romantasy in particular. I love reading all books, honestly, and I love watching anime. And anyone here knows Angus, I also have a cat called Piper. All right, so dysautonomia is a broad term that describes disorders of the autonomic nervous system, or the ANS. The ANS is part of our nervous system that controls involuntary bodily functions such as heart rate, blood pressure, digestion, temperature, regulation, and even pupil dilation. In people with dysautonomia, these functions kind of go haywire, and it's like the body's autopilot system becomes a bit unreliable, so it's not functioning the way that it should. So the autonomic nervous system is broken down into two parts that work in opposition. So the sympathetic nervous system is responsible for your fight or flight response. This is supposed to be in response to stressful situations, as it is there to help you respond to any threat. It does this by speeding up your heart to get more oxygen around your body to meet the physical demand of potentially having to run for your life. Pupils widen to take in more information. Airway muscles relax so that you can get more oxygen in. Digestion slows and saliva production decreases because the energy is diverted away from those functions in order to deal with any threat. And the bladder relaxes to reduce your need to pee while hypothetically running. So the parasympathetic does the opposite. So decreases heart rate, constricts pupils, tightens airways, increases digestion and saliva production, and constricts the bladder so you can go pee again. So postural orthostatic tachycardia syndrome, or POTS, is the number one most commonly known about cardiac dysautonomia within the hypermobility population. So let's have a look at that. So POTS is a type of cardiac dysautonomia, and it is more common in women at a 5-to-1 ratio, women to men, and is more common in ages 15 to 50. So the primary symptom of POTS is an increased heart rate or tachycardia on standing, especially from lying down, but also from sitting. This can feel like palpitations or chest pain, but most commonly it is reported as dizziness or lightheadedness and blurred vision or other visual disturbances such as floaties or sparkles or anything like that. Other POTS symptoms that not everyone is aware of. So you can have the neurological symptoms, including brain fog, headaches and migraines, numbness or tingling, especially in the extremities, tremors or fainting, which is pretty rare. A lot of the people out there think that you have to faint to have POTS, but that's not the case at all. In fact, most people don't. Gastrointestinal symptoms, we have constipation, bloating, and nausea are very common in POTS. Can also have some diarrhea, but that's usually related more to MCAS, which I'm going to go through in another 2 months. Respiratory symptoms, we get shortness of breath or air hunger. It can be sudden shortness of breath for no apparent reason. Fun fact, I experienced that for the first time last weekend. It was really fun. I would highly recommend. The other one is exercise intolerance. So obviously there's a few things that are going on in the body that mean that oxygen isn't getting around enough. So then when you're doing exercise and exerting yourself, you have higher air oxygen demands, and your body is already not keeping up with the ones that it has at a bare minimum. So that can be a big problem for people with POTS, any cardiac dysautonomia at all, but especially POTS. Urinary symptoms, we get urinary or urgency or feelings of incomplete emptying, for the reasons we said before about the bladder relaxing and not doing what it's supposed to be doing properly, that then when it comes back online, it kind of goes, holy shit, what's going on? And then similarly, it doesn't work efficiently, so it doesn't always necessarily empty properly. We also have general symptoms such as extreme fatigue, sleep disturbances, and trouble regulating temperature. I know almost every one of my people have cold hands, cold feet all the time. And me included. If you ever come to see me as an osteopath, I will always say sorry for the cold hands, even if they're not cold, because it's just that rote learnt. All right, so why does POTS happen? There are a few subtypes of POTS depending on what the cause is. So the neuropathic subtype is caused by a reduced sympathetic nervous input to the veins in the lower limb, causing a reduced constriction of those veins in order to push the blood back up to the rest of your body, leading to excessive blood pooling in the legs. When we have the hyperadrenergic, so 30 to 60% of all POTS cases are considered to fall under the hyperadrenergic type. This is caused by inefficient transport of noradrenaline, leading to significantly higher levels in the plasma, especially when standing, which causes the tachycardia. It stimulates that sympathetic nervous response. We have the hypovolemic type, which is seen in 70% of cases. So obviously those are not mutually exclusive. You can have multiple things contributing to this, which would just potentially make your case more serious or more symptomatic. So it's seen in up to 70% of POTS cases. These cases show varying degrees of decreased plasma, red blood cells, and total blood volume. This is why it's common for people with POTS to have worsening symptoms in periods of dehydration such as illness or sport. And I was writing this yesterday, dehydrated as hell, and every time I got up, I felt really dizzy. So that's where that one came from. And another hypothesis of why POTS occurs is that of autoimmunity, which means that the body develops a response to an attack, but there is actually a thing that's coming out and attacking, which is what your immune system does. Autoimmune means that that immunity is then targeted against your own body and its own cells. All right, so diagnosing POTS requires a careful clinical history and orthostatic testing. This may include, please hold 1 second. I'm going to go get a dog. Angus, come here. Sorry, guys. Come on. Come in. Just shut the door behind him so he can't get back out. Come on in. You're a menace. Sorry, some dog was walking past the clinic and he likes to tell them to go away. It's his place. So diagnosing POTS requires a careful clinical history and orthostatic testing. So this may include the Malmo POTS score, which some of you will be familiar with because I've made you do it, which is a questionnaire of POTS symptoms. So a score on that one equal to or above 42 means that the person is likely experiencing symptoms of POTS. And that's usually the cause of what those symptoms are, because a lot of the symptoms are very varied and they can happen because of a lot of reasons. But basically, if you score 42 or above on that questionnaire, it means that your symptoms are most likely because of POTS. One common physical test for POTS is the Nasoline test or the active stand test. Again, some of you will be familiar with it because I'm now running this in the clinic as well. So this involves measuring the heart rate and the blood pressure when someone has been laying down for 5 to 10 minutes. I always say 10 just to make sure. The person is then asked to stand up, and in the Nasoline test, you lean against the wall, which is my preference, just in case you do get faint and pass out, then you just got to slump down the wall. You're not standing in the middle of the room. The person is then asked to stand up, and their blood pressure and heart rate are checked every minute for 10 minutes. So if the heart rate increases by 30 beats per minute in adults and 40 beats per minute in adolescents within the 10 minutes, or if the heart rate exceeds 120 BPM at max, without a drop in blood pressure of 20/10 millimeters of mercury, so that's 20 systolic and 10 diastolic for those that care, is in the first 3 minutes, then and the person has had ongoing symptoms for at least 3 months, then a diagnosis of POTS is suspected. So that's one of the troubles is I can do that test for you in the clinic, but I can't tell you have POTS. You have to get the diagnosis from a GP. And a lot of the GPs aren't up to scratch with what this entails and often will send you off to a cardiologist, which we all know is a big problem. In more complex cases, they can also do a tilt table test, but that's basically just a very extreme version of this that is more expensive and less accessible. So what happens if you don't get a positive result on the Nasoline test? Unfortunately, POTS is a highly variable condition, which means that it can vary from day to day. If you are still experiencing the symptoms upon standing that are associated with POTS, but you are not seeing a positive result in those criteria of the Nasoline test, then we call it orthostatic intolerance, because it's basically orthostatic means standing up, it's postural change, and you're intolerant of that because your body is not coping with that. And that's not to say that a negative result means you don't have POTS, just means you're not displaying POTS at that very minute. So that's lovely and fun. Similarly, if you're experiencing the blood pressure drop in the first 3 minutes that the test has to exclude, that's because this is indicative of postural hypertension, which is what the cardiologist told me I have. Not true. Basically, you have to have that 3 minutes of stable, because what happened with my test, for example, I dropped in the 8th minute. So that means that my heart was beating really fast, but it didn't quite get where it was supposed to be, and it still had that problem happen. And I think it's really important that all health professionals be aware of that. So these conditions are still classified in the cardiac dysautonomia umbrella, and lifestyle management strategies will still apply. So a lot of these things will have the same symptoms and certain things. It's just basically the only difference is the medication side of things. If there is the tachycardia, we will have, the dog. We will have medications that can manage the tachycardia side of things, but less so if there is a hypertension there as well. Okay. Lifestyle changes form the foundation of management for all cardiac dysautonomia. Increasing salt and fluid intake can increase blood volume and support circulation. The recommended daily intake for a person living with POTS or any other cardiac dysautonomia is 2 to 3 litres of fluids. So that doesn't just include water, but like if you're having soup for lunch, those kind of things, because a lot of us are also neurodivergent and can't remember to drink water. So that's why fluids is there. Then also 10,000 milligrams of salt. So that's 10 grams of salt per day. This is variable, and obviously there are other things that salt can have an impact on, but that's what the Canadian standard of treatment they found, and they said that that was the indicative amount. I think most people trying to get 4 or 5 grams of salt per day is good, because also we're talking about the sodium and not just salt, so not the sodium chloride component of salt, but just the sodium. So that's not an equal weight thing. So high sodium electrolyte drinks are a fantastic way to increase both sodium and fluid intake. I personally recommend Sodi, as they contain 1,000 milligrams of sodium per sachet and are an Australian company that is made with no unnecessary additives. And it's also Western Australia lake salt that they make it with, which I love, a good Australian brand. I'm in the process of trying to organise stocking these here at the clinic, and I'll let you guys know on Facebook as soon as I have them. Medical grade compression garments that are 20 to 30 millimeters of mercury, can reduce blood pooling in the legs. So that includes compression. So those compression garments should ideally be ankle to waist. So that is obviously starting with socks is the most readily available one, and they're much cheaper than the tights. So I really like the Funky Sock Co brand, and I'm also trying to work with them to get like a discount code or something that I can give to, because I keep telling everyone to buy them. And compression tights such as Supercore, which is the brand that the POTS Foundation recommend. I know there's a few other medical grade compression with tights or leggings that people have out there, but those are the ones that are specifically designed for POTS in mind, to have POTS in mind. I have not had anyone try them yet. So if anyone's tried them, please let us know on the group because we would love to have some feedback. I'm pretty sure both of the people here are the ones talking about looking at them. So there's a bit of a conversation on there already. If you've got anything to add, we would love to know. So people with cardiac dysautonomia are also often advised to engage in a carefully graded exercise program. So this means working with whatever capacity that you have. If that's 2 minutes a day, that's 2 minutes a day. This typically starts with recumbent exercises, so laying back a little bit, such as using a recumbent bike. So that's the one where you sit and have the pedals out in front of you, and gradually work to more upright activity as tolerance improves. This is obviously for very severe cases, but most cardiovascular exercise will be beneficial for this. If you're struggling to exercise, please consider working with an exercise physiologist who is aware of POTS. So I just wanted to shout out here Jemima, who is in the group, and she works exclusively online at Visible Exercise Physiology. We have linked her in that spreadsheet that I've just made of all of the practitioners in Canberra. But she is also available online to anyone not in Canberra. Medications are sometimes used to help manage POTS, although they are tailored specifically to the individual. They can include beta blockers and a few other different medications that I'm not going to bore you with all the names of, because the GP has to be managing those, or a cardiologist. So it's important to note as well that in Australia, access to these medications can be financially challenging for some patients, as not all of them are listed on the PBS. All right, so that's all of the information part. So I just wanted to shout out upcoming appointments. That's why I've just gone and made all of the new events yesterday. So everyone got invited to those all at once. And in doing so, I then realized there was a couple of people I didn't invite once they joined the group to today. So sorry if you're one of those. I hope you're seeing the recording. So the next event that we have coming up is the 20th of July. So we're doing like a social crafty meetup in Woden. And then the 24th of August will be the next education session. And I will be talking about mast cell activation. And oh my gosh, I'm terrified. It's a huge topic. So today was a nice little quick and short one because it's quite a simple thing. I think mast cell activation will be the opposite. I will try and simplify it as much as I can though. And then we'll go back to having a Northside meetup on the 14th of September for the crafty side of things. And then I have Rhea Braun, who is an osteopath in Canberra at Fundamental Health, and she's a women's health osteopath. She's done her master's in women's health, so she will be coming to talk to us about pelvic organ prolapse, because she was the one that diagnosed me with mine after I was talking to her and didn't realize I had one. So I wanted her to come and tell everyone what the symptoms and things are, and I'm trying to wrangle if we can fit in the stuff about the gynecological stuff like PCOS and endometriosis, and talk about those as well if we get time in there as well. Otherwise, I will try and wrangle her back to come back next year. And these are the links to the places I got all of the information. All right, I did that in record time today, so I'm glad that I wasn't taking too much of your time fuffing around. I probably was equally as fuffing around as I was getting the information there. So I will be posting this video up on YouTube in the next day or two. Last time it took me a couple of days to figure out because it was being a pain, but I will post all of that information up there and I will talk to you guys later. I'm just going to, oh, nope, it's on the wrong screen again, Steph. Oh, we have a chat. Cool, Rama, thanks, Ambrose. All right. I can't even find the stop recording. I'm just going to end. Oh, there it is.